We are about 2 minutes in, so we can go ahead and get started. I just wanted to welcome and thank you so much for joining today's webinar. My name is Melissa Huey. I am a Principal Medical Liaison in Clinical Nutrition here at Baxter, and I will be your moderator today. We have a great presentation ahead titled Behind the Bag, Optimizing PN Production from Order to Delivery. So before we get started, I'd like to go over a few items so you know how to participate in today's event. You see here a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop. You will have the opportunity to submit text questions to today's presenter by typing your question into the Q&A window. To activate the Q&A window, you will need to click on the Q&A icon at the top of the webinar window. The Q&A window will then be brought up and you may type your question into the field labeled "Please input your question." You may send in your questions at any time during the presentation. We will collect these and address them during the live Q&A session at the end of today's presentation. Also, this session is being recorded and will be posted to Baxter's Clinical Nutrition Medical Education website in that vein, which may be accessed by visiting meded.baxter.com and clicking the link for clinical nutrition. We will also share a QR code to the site at the conclusion of this webinar. Finally, at the conclusion of the webinar, you will see a QR code for a brief survey. Please take a few minutes to complete this survey as it will help to inform us on topics for future webinars. And now to introduce today's speaker. Abbi Rowe is the Director of Pharmacy at Advent Health's Central Fill Pharmacy in Orlando, Florida. She received her Doctor of Pharmacy degree from Mercer University, completed 2 years of residency training with a focus in health system pharmacy administration at Advent Health Orlando, and obtained her Master of Healthcare Administration from Adventist University of Health Sciences. In her current role, Abbi oversees daily workflow at the Central Fill Pharmacy, which includes parenteral nutrition, sterile compounding operations, and provides supply chain management oversight for the Central Florida division of Advent Health. Additionally, she serves as the residency program coordinator for the PGY 1 and 2 Health System Pharmacy Administration and Leadership Program and precepts pharmacy students as well as PGY 1 and PGY 2 students. And now I will turn it over to Abbi.
Thank you very much, Melissa, for that intro. Just to go over a few disclosures, I have nothing financial or non-financial that I need to disclose today. And then we'll go ahead and get started. So thank you all for joining me today for this webinar. Really quick, thank you to Melissa for the intro, but thank you to the whole Baxter team for coordinating this. I'm excited to take you all through our journey to improve parenteral nutrition or PN operations here at Advent Health. So we'll go ahead and jump in. Today, our objectives are to highlight the clinical rationale for PN standardization and how it enhances patient safety. We'll explore some operational strategies to streamline PN workflows, reduce variability, and leverage automation and technology. And then we'll wrap up with some real-world outcomes and lessons learned from our implementation efforts here. So to start, I kind of want to set the stage and give you just a little bit of context around Advent Health in general and our parenteral nutrition operations. If you aren't familiar with us, Advent Health has a nationwide footprint. We've got 56 hospitals across 9 states, and the majority of the facilities are located down in Florida, roughly half of our facilities. We divide the state of Florida into 3 different regions or divisions. We have an East Florida, a West Florida, and then the Central Florida division, or CFD, where all of the work that I'll be talking today takes place. The Central Florida division includes 9 hospitals, soon to be 10 hospitals in December. We've got a new hospital going live in December with over 3,000 beds. So a pretty large health system here in Central Florida. We also have 11 freestanding emergency departments here in Central Florida. Additionally, we're the only division in Advent Health that has a central fill pharmacy or CFP. All of the hospitals and ED facilities, as well as the Central Fill Pharmacy, are located in a tight, roughly 30-mile radius, and that is really key, one of our keys to how we're able to successfully provide some of the services that we are able to provide out of this location. So digging into the central fill pharmacy, or CFP, a little bit more, we should start by probably clarifying what our main scope is. I feel like I talk to a lot of people out in the industry, and when I hear central fill pharmacy, it usually describes a mail order pharmacy, but we are completely different. While Advent Health does have a mail order pharmacy up the road in Apopka, we provide services and support specifically to our acute care sites, so those hospitals and freestanding EDs. Our location was established about 12 years ago, back in 2014, and the main goals then were to really optimize logistics and efficiencies for the campuses by establishing the infrastructure for some centralized services. We wanted to develop a warehouse space where we could house reserve supply for essential drugs and, help combat drug shortages that we were experiencing at that time. And we also wanted to establish some sterile compounding operations to be able to support insourcing the production of a select set of high-use products throughout the division. If we fast forward to today, over the last decade, we have changed a little bit. Some things have morphed, but our core services include parental nutrition compounding, which we'll detail a ton throughout the rest of this webinar. We also do automated dispensing cabinet replenishment. We do a ton of oral solid medication repackaging. I think we're up to close to 2 million doses of pre-packed medications annually now. And we provide just kind of general supply chain support for the division. So contract compliance, drug shortage management, direct or bulk buy savings opportunities. We've also centralized buying out of this facility. And then lastly, and honestly, probably most interestingly, we've developed an internal environmental monitoring team. And so they are well published and do a good job of telling their story. But you can kind of get the vibe. We really like to in-source services here. And this team is so clutch. So this team's made up of a bunch of microbiologists, and they travel out to our Advent Health facilities across the state doing monthly air as well as surface sample testing in all of our clean rooms. And so I cannot tell you from a compounding perspective how lucky it is to have this team of experts literally one door down in the building. So this is a layout of our current space, and I don't want to take too much time here, but I just show this diagram to illustrate that you really don't need a ton of space to be able to start some kind of centralized service work. And I know that there's a lot of health systems today who are either in the middle of building out one of these facilities or, preparing an ROI for what a facility like this might be like, which I think is great. It's been such a beneficial add to our division. But this was our original floor plan, and you'll notice that the total footprint comes to right at 18,000 square feet. And so if we draw attention to the area here in the red box, this is our clean room operations. So again, not a whole lot of footprint. As I mentioned before, one of the main goals of the original plans was to establish a strategic compounding operation here. And so this plan really centered around creating some dedicated space to decrease our reliance on outsourced CSPs. So remember, during this time frame, this was right at the wake of the NECC tragedy. And so if you haven't picked up the Kill Shot book, I think it's a great story if you're a true crime fan. Unfortunately, it is I say a great story. It's an interesting story. It's certainly a story of many lessons learned, but terrible tragedy that happened at NECC. And so kind of building off of that, we wanted to pursue higher quality in our compounded products. That was the top priority. So let's establish some compounding space. So this slide zeroes in on that compounding space that was part of the original plans. You can see here it was actually split into 3 separate rooms, one of which that is labeled a chemo room is a negative pressure room. And altogether, this represents about 2,000 square feet. The parental nutrition compounding that we do today, and let's see if I can get this to work. Oh yeah, laser pointer. The compounding that we do today takes place squarely just in this room and not in these other 2. So we'll talk about, this pivot a little bit as we continue through the webinar. But again, not a whole lot of space required for this project. In 2027, we did have to make a pivot. So following an official state clarification on the scope of practice that they allowed out of 503A licensed facilities, and following the FDA's proposed guidance that I'm sure many of you are familiar with, that limits how far compounded products could be distributed that are non-patient specific, we had to make a pivot from that vision of batch compounding and doing a lot of that work here centralized. So we were looking for something that was patient specific, that would represent the best value for the division, and parental nutrition became a pretty obvious target. When we started investigating the feasibility of insourcing something like our parental nutrition compounding, we started looking at contracts. And the one that we had in place with our outsourcing facility was interesting. We found that we were routinely paying about 30 to 40% more than what the contracted prices were, because that contract price was based on just the macro ingredients being used. And so if you are familiar with the PN space, there are a ton of micro ingredients that get added to these bags. And that was really jacking our cost up more than I think a lot of people had good insight to. There was also a pretty high cost of delivery associated with that process. And so PNs ended up being a really good savings target and kind of the route that we wanted to go. So that gets us into our current operations. As I said, no batch compounding now, only patient-specific doses. And so we don't really have a formal use for those other two clean room suites. We do service all of the hospital facilities throughout the Central Florida Division, which has us making 60 to 70 bags a day. And roughly a third to half of those are for neonatal or pediatric patients. And then we do run that operation 365 days a year. So I'm a Southerner, all the old sayings, I might incorporate some here, but come hurricanes or high water, we are able to get these parental nutrition bags out to our patients. So now we've got a little bit of a history lesson under our belt. We'll briefly go through what the workflow looks like on a day-to-day basis. So for our parental nutrition operations, the shift starts at 7:30 a.m. And as recommended by ASHP guidelines, daily compounding is directly overseen by a pharmacist and performed most days by a single pharmacy technician. The bottom half of the slide really details our PN schedule. We have a dedicated pharmacist and technician who both do 10-hour shifts. And then additionally, you'll see that we have a second technician for an 8-hour shift one day each week to help with some prep work. And we'll cover some details about it a little bit later. So altogether, the FTE footprint for this operation, 3.7 FTEs earmarked for PN compounding specifically. While the pharmacy technician garbs, enters, begins cleaning the room for the day, the pharmacist reviews the orders from the previous day. And in an effort to promote sterility and limit airflow disruptions, we've really stressed not having excess supply in the room. So the pharmacist is outside of the room and they are estimating the needs for the day, getting each of the items ready. All of the products, whether it's drugs or supplies, are cleaned and disinfected before they're transferred into the clean room via a pass-through window. And so then just after 9 a.m., the tech starts to work on getting the automated compounder set up. And so as highlighted again by ASHP guidelines that many of us use and follow, automated compounding devices or ACDs really provide they're a great resource for this kind of insourcing work. It improves our final product accuracy. They help to enforce proper compounding sequences, and then it also aids in reducing contamination. The compounded device is calibrated and set up in accordance with the established additive configuration. That's the only way it can be set up. And the model we use has 24 ports for up to 24 different ingredients, and we use every single one of those ports. So once the first phase of the setup is complete, around 10 a.m., the pharmacist garbs up, enters the room, primes the tubing, inspects all of the lines, and verifies that the compounder configuration is set up appropriately. Then around 10:30 or 11 a.m., we start to finally see some PN orders actually start coming through. And this leads to another significant update in our process that happened in 2022. So we implemented an IV workflow management system into our PN operations. And since that's a mouthful, I might say IVWMS, but I might muddy that up too because that's an awful lot of letters. But pre IV workflow management system, our technicians running the compounder really had very little direction regarding bag prioritization. So as orders were completed and the labels were printed, they were just handed off to the technician. And so we noticed that we were having some production delays with this kind of first ordered, first compounded method when we weren't really taking regard into the delivery schedule into play. And so that had the potential to cause some delays in the distribution process. Once we implemented the workflow management system, the pharmacist was able to queue orders much easier and make sure that they are completed in sync with our established delivery schedules. The IV workflow management system also allowed for remote order verification. So before it, the pharmacist was stationed inside the clean room for the duration of the shift every single day to be able to check any manual additions that were needed to our PN bags. But now, once the pump's verified, they're able to exit the room, work remotely just outside of the room and check the details through visual pictures that are included in that system that you see here as a snip on the slide. Additionally, the IV workflow management system greatly expanded our reporting capabilities. It also provided some really key product labeling enhancements, and we'll get into some of those details a little bit later on. So then continuing through, oops, sorry for the laser pointer. Let me turn that back off. Continuing through the rest of the workday and into the afternoon, the majority of PNs are compounded between 11 a.m. and 3:30 p.m. And that's when our couriers start to come by to pick up the deliveries. This slide just shows a breakdown of our order cutoff times, our estimated packaging times, and then the subsequent courier pickup times by each of the campuses that we service in our division. So we use an internal Advent Health courier team for all of our campus deliveries, which again is a huge benefit to our operations here. Finished PN products are individually bagged with filters transported to the campuses in insulated totes. And we have a standardized hang time across our division of 8 p.m. So the delivery schedule gets set to accommodate all doses being delivered to campuses 6:30 p.m. at the latest. And they are ready to go to patient rooms for administration by 8 p.m. Okay, so that was a quick background, but I hope that's kind of set the stage, and now you know a little bit more about our setup. And so in this next section, we're going to highlight some of the clinical rationale for PN standardization. In 2021, experts from the US and Europe came together at the International Safety and Quality of Parenteral Nutrition Summit. And the goal was to evaluate current PN practices and help develop consensus statements to help address patient safety and various quality concerns. So in this graphic on the right, they outline really well each step in the PN process and the potential sources for error, as well as the range of reported incidences of error related to each of these steps. And so we're going to kind of use this graphic as a roadmap as we move through the next few sections, because I think it really highlights a lot of the clinical and operational processes that we've put in place and why we've put those in place to mitigate some of these errors. So if you're tuning out for the rest of this, the cheat code, the big takeaway, the big point really is that standardization is key. Standardization across all of the various frameworks, whether it's the prescribing process, the preparation process, the administration process, that's really the essential piece for making parenteral nutrition both safer and the operations around it more efficient. So that's the cliff notes, that's the important part. But for all of you who are still here with me, who are going to continue on this journey, we will start at the very top of this graphic and consider some of the errors that could be related to the initial assessment or reassessment step. So observed errors that are seen here and noted by the group, or the PNs are not indicated or could be inappropriate, formulation or clinicians who lack the experience to do some of these monitoring and assessment steps, an absence of essential PN components, PNs that are not adjusted or monitored appropriately, and then monitoring that's just not ordered or reviewed. So one of the ways that we really try to tackle those types of issues is through a multidisciplinary approach. As the old saying goes, two heads are better than one. And so at Advent Health, our pharmacists, our pharmacy team is consulted and work very closely with our physician staff on every single parenteral nutrition order. And a parenteral nutrition order cannot be placed without a pharmacy consult. And so the workflow is illustrated in detail a little bit here, more on the right side of the screen. And to be fair, this is probably an oversimplification of the process. But in general, the process starts with pharmacist number one. They receive and or review parenteral nutrition consults in the EHR. So new consult or an existing consult, they're reviewing those orders every single day. Pharmacists throughout our division have scope of practice to order any labs that are necessary for the development of the PN formulation. So they do that, review the consult, and then they come up with a plan. And so if it's a new patient, they have to add that new patient to our order entry system. If it's an existing patient, they're just looking at that patient in the order entry system. They select the appropriate template, enter the order, transcribe the order into the EHR. So they are entering that order into two different platforms. And then pharmacist one is kind of done. Pharmacist two then receives notification that the order, that there's a completed PN order in the EHR. They log into the order entry system and verify the order in the PN order entry system against what is listed in the EHR. If they identify any kind of mismatch, they are selecting, it's a field in the order entry system called finish later. It's basically like putting an order on hold. So they put the order on hold, reach out to pharmacist one, discuss the mismatch, and then pharmacist one is responsible for addressing any kind of mismatch. And then the process kind of starts itself over. The second pharmacist again is notified, logs in, does this review of the two orders, make sure that they match up. And if they do, they submit the order in the EHR and the labels are automatically routed to print at our central fill facility, this offsite facility. Order entry cutoff times are listed here. So 2:30 p.m. for adults, 4 p.m. for peds and neonatal orders. And then they just select done in the order entry system and it's marked as complete. So again, probably an oversimplification, but throughout the whole process, the key takeaway is that the pharmacist has open communication for any questions or discuss patient details with physicians, nurses, dietitians, care managers, really the whole team that's on that patient unit. Back to our graphic, the next step in the process is the prescription or the prescribing process. And so errors here typically center around doses that are outside the normal range, incorrect volumes, or incompatibilities. And so when we think about how we try to mitigate those, the main safeguards are really built into our PN order entry system. And so we are trying to use that to its full capacity. First off, in the software, we are able to make customized templates. And so these templates are based off of patient types. You'll see those patient types listed here. We currently have adult, adolescent, pediatric, and neonatal patient types that are assigned based on the parameters in this table. And all of these template designations also have a peripheral template as well as a central line template, depending on the route of administration. Next, we have warning levels. So warning levels of low, medium, or high can be assigned, and each level is assigned allowable actions. So the right side of the slide shows the available actions and what each of them allows or results in. So if the report immediately action is checked for that specific level of that specific drug on that specific template, so this is really customizable, the software will display an alert whenever a value is entered that exceeds that limit. For the allow override action, it does exactly what it sounds like. It allows users who have the appropriate permissions to allow an override. Allow any user override, that one's pretty self-explanatory. The next one, require rationale. This pops up a text box so that the entering pharmacist has to enter a reason for the override in that box. And then the last one, print warning on label. If that box is checked, then that means that the warning will the warning that a level exceeded its limits will print on a designated label. So then we get into the next layer of this kind of stinky prescribing process onion, and it's warning limits. So warning limits describe the actual minimum and maximum allowable values. There is a visual color-coded indicator that pops up on the screen whenever you are entering these orders that quickly and easily allows the entering pharmacist to know based on the color kind of what's going on with the order. So green indicates that there's no parameters outside of the limit values. Everything's good. Yellow would indicate a warning exists, but it's informational only, or it's something that can be overridden. And then red is basically a hard stop. That's showing that a warning exists and it can't be overridden. You've got to go back into that order and change something. Won't spend too much time on this slide in the interest of time, but just want to note that other properties outside of just ingredients specifically can also have warnings applied to them. And so there's tons of different parameters where this software can really help establish some guardrails for our prescribing process. As we continue around this graphic, the next step in the process is order review and verification. So here the group highlights misinterpretations, lacking or insufficient evaluation for compatibility or stability, and then wrong or missing ingredients as potential areas for error, with reported incident rates between 20 and 39%, which is a pretty big metric. For this one, I really go back to standardization. So I gave you all the background of how we pivoted to PN compounding. And at that time, whenever we insourced, we did a global assessment of all of the templates that were being used and common ingredients that were being ordered. And so using evidence-based recommendations, guidelines, we made the decision to remove several ingredients. These included insulin, folic acid. We removed potassium acetate, leaving sodium acetate as the acetate electrolyte. We removed sodium phosphate, leaving potassium phosphate. And then we streamlined amino acids as well. So we removed the 10% amino acids from the adult templates and left the 15% amino acids. Additionally, we decreased the recommended zinc dose. So again, based on evidence recommendations, decreased that from 10 mg to 5 mg. And so by kind of doing that cleanup work, limiting what ingredients are approved and even available on those formularies to be ordered, we were able to standardize a PN formulary to be used across the entire division. And then this slide just shows, again, a visual representation of a comparison of our adult templates before and after that cleanup. And so with just a quick glance, you can tell that it's a much simpler formulary and therefore definitely a safer template that we've moved forward with. The last piece that I'll touch on here is when we think about streamlining is the PN standard formulations that we've developed. So shortly after we insourced, we recognized that a lot of the custom bags that we were making each day were pretty similar in their formulation. And so this prompted us to develop some unique in-house standards. These are pretty similar to the commercially available PN options that I'm sure you're all familiar with, but they are a little more tailored to our practice here at Advent Health. And so when we started out, we identified 2, and then we had a resident come along who did a really high quality, really great, thorough MUE on our parenteral nutrition orders and identified a 3rd formulation. So we have 3 total now, and they're all available with and without lipids. And the benefit of establishing these standard solutions was multifactorial, but they contain limited additives. And so just by nature, they are cheaper to produce than most custom formulations, and they can be batch compounded ahead of time. So while our 503A license limits us in not dispensing any batched compounded products, we are able to batch them and then dispense pursuant to that patient-specific order. So definitely some operational efficiencies were gained there with the use of these standards as well. All right, speaking of operational efficiencies, we will switch gears and merge into some of the more operational strategies that we've implemented throughout our insourcing journey. So back to our error graph for just a couple more of these steps. Continuing around the circle, the next one is preparing, compounding, and dispensing. And so common errors here include product mix-up, lacking sterility, incompatibility, or missing additives, incorrect or missing labeling, and then incorrect storage. And these account for somewhere between 24 to 42% of reported errors. And so here I think is a good place to go back really briefly to provide a little bit more detail about these automated compounding devices that we talked about at the beginning of the presentation. So if you are looking to insource PN operations at your health system, and there is only one takeaway from this webinar that you can implement, getting an automated compounding device is 100% it. They are awesome tools. They are able to reliably transfer volume as low as 0.2 mLs. And so when I think about that, I mean, 0.2 mLs is such a small amount of volume. That's just a whiff of some of these ingredients. And so they're able to handle really small volumes. They can facilitate up to 24 different ingredients, and we use every single ingredient port on our compounder. They're equipped with gravimetric scales that can be used to validate final bag weight versus the expected bag weight. And they're also able to direct the appropriate ingredient sequencing that I mentioned earlier. So I really can't stress enough how important these are. I cannot imagine doing any appreciable volume of PN compounding manually, and ACD is definitely key. Pivoting back to our IV workflow management system, a little bit more here. So I'm sure the concept of this is not new to anybody, and I'm sure many of you might be using it in your clean room suites in your hospitals, but it's really been a good add to our PN process. And you might be going, Abby, the compounder holds 24 ingredients. You don't need it for very much. That's true. The compounder does most of the work, but every now and then we do have manual adds that we have to add. And so it's great for that. And then it's also great to support what we call our batching activities. So creating stock solutions has allowed us to maximize the number and volume of ingredients that we hang on the compounding device. And so that has helped us minimize the amount of manual additions that we have to do. We have two categories of stocked solutions. We have pooled, my Southern accent comes out a lot when I say pooled stock solutions, as well as dilutions. And the tables here on the right side of the screen detail what products we are manipulating and either making those pools or dilutions. So we're able to batch some of these ahead of time, as well as those standard bag formulations. And the IV workflow management system really helps us manage that work and communicate it and queue it appropriately, and really streamline the process between the pharmacist outside of the room and the technician who's inside of the room, inevitably doing most of that work. And so you'll remember from the table at the beginning that I mentioned that we have that additional technician who comes in 1 day a week and does 8 hours in the IV room. The primary role of this individual is to accomplish some of this batch work. I'll touch again on the benefits of the pharmacist being outside of the room. So easier communication has been huge for us. We use team chats, team channels everywhere. And so we established a dedicated parental nutrition team chat to help facilitate communication between our 9 hospital campuses and the compounding pharmacist who is at the central fill facility. Outside the room, we're able to have multiple monitors set up. And so that's really helped the response time and being able to streamline that communication piece. It's also helped with better inventory management. So before we had the pharmacist in the room, if they didn't estimate the ingredient or supply needs for the day appropriately, then they were trying to call somebody outside of the room who's not a dedicated resource to the PN operation, just trying to kind of grab somebody and say, hey, could you send us in a couple more empty bags? Could you send us in a couple more, vials of this ingredient? And so having the pharmacist outside of the room, they are really able to own that process and make sure that our inventory management system is updated appropriately. And then we've also seen some improvements to our distribution process. So as I mentioned before, we really want the product to be ready to go straight to the patient floor by the time it gets to the campus. So the pharmacist on the outside is able to do kind of a final check, make sure all the labeling looks accurate, puts the final product in a bag, and couples that with an appropriate filter. And then we do send all of our products out in insulated totes. So they're also able to coordinate that, make sure that everything is packaged appropriately, has the appropriate ice packs, and so that it can make it to its final destination within the appropriate temperature scales. Last but not least on our error graphic is the administration step. So errors associated here most commonly are related to wrong patient, dose, drug, route, time, or contamination of the infusion center, the infusion system. And so the ability to consolidate down to a single label has greatly helped us here with all of those potentials for error. So before we implemented that IV workflow management system, the final PN bags looked a lot like the picture on the left. So we had 2 labels on each bag. The larger one that you see on kind of the left side of that picture was specific for the compounding device. And then the one that you see on the right side was needed to allow the nurse to BCMA scan into the EHR system. As you can imagine, this could be quite confusing for some of our newer nursing colleagues and had the potential for error. So anytime we had names that were similar, it seems like it would be particularly common with twins or triplets in our pediatric population. We had the possibility that the labels got mismatched. And so here at CFP, we were confident, we felt really good that we knew that the compounder label, that bigger label, was the source of truth. And we tried to message that out, but fairly, the teams at the campuses didn't feel confident about that. And so if there ever was a mismatch, which I'm not saying happened frequently, but certainly did happen, typically the dose was held. And so that created waste, but more importantly, it, had impacts on patient care. So fast forwarding to what our operations look like now, we are very proud that we were able to work directly with our vendor to consolidate to one final label. And so I know that the graphic on the right side has a lot of information blocked out there, but you can see highlighted in the colored boxes 2 barcodes. So the barcode that's in that blue box is the one that's specific for the compounder, and then the 2D barcode that's down there in the red box is specific for the nurse to scan for the EHR. So it's kind of hard to see down there, but it actually says nurse scan right here, right above that barcode. So the collaboration with the vendor to be able to get this down to a single label has been a huge accomplishment for us and has really greatly reduced the risk of inappropriate labeling, errors related to that inappropriate labeling. All right, we are all the way through that graphic, but I would be remiss if I didn't touch on just a couple of other operational points. And so just have to mention inventory optimization. And so I'm sure you're all aware product shortages have been and continue to be a challenge, especially for PN components. While shortages also pose just as much of a problem for outsourcing facilities as they do for us who insource, being able to identify those earlier has really allowed us a faster and more efficient and more reactive response. So from the beginning, we decided that we were going to keep minimum of 3 months of what our average use looked like on hand of all ingredients, drugs, and supplies. And so it was really important for us to make solid plans around this. We wanted to build confidence among our customers, the campuses, our clinicians, that we were prepared to take on this work, but also to overcome any shortages that might come our way. And so we feel like this 3-month window is a great buffer time. It allows us some time to react, to make a plan if there is some kind of change that's needed without having to hustle and do something real quick at 5 o'clock on a Friday afternoon. And so when we can't avoid drug shortages, we definitely lean on the many organizations that are out there that provide recommendations about what to do. I have a super nice reference table with a lot of those resources. If anybody would like it, I'm happy to share that after the call. But the key takeaways that we really noted here with inventory optimization was that it was super easy to use our historic data to anticipate needs, set inventory levels. I would definitely make sure you consider available storage space. So I know I've been preaching the sermon of you really don't need that much space to centralize this stuff. When you think about the inventory that you need, it can require considerable space. So 3 months of some of these larger volume fluids can take up quite a bit of room. And so 3 months of, amino acid bags or lipid bags or dextrose bags is represented by pallets. So making sure that you have appropriate space is definitely important. Establishing a process to receive early alerts of supply disruptions are important, and then always leveraging your strategic relationships that you have with manufacturers and vendors. And then wrapping up quickly this operational section, how do we manage the operations when shortages do occur? It's largely dependent on the particular shortage. Lots of times a pediatric or neonatal formulation can be used in place of an adult one. One electrolyte can be subbed instead of another. Dosages can be adjusted or given less frequently to help stretch supply. But I think it's really important to note here that we really need pharmacists involved in this step. It's not just any drug shortage. There are compatibility issues that come up that we need to address. We need to assess if there's any changes needed for the EHR or for the compounder. We have to be able to document those changes so that we can reverse them once the shortage recovers. We don't want to get stuck in mitigation mode. And we also want to ensure appropriate communication to our frontline staff. And then again, I'll just touch on interdisciplinary collaboration. Key implementation goal for us was really minimizing disruption for frontline staff. And so we knew that we would be successful in this insourcing journey if our, physicians and nurses really didn't know that a change was even happening. And so we wanted to avoid the need for large scale retraining and kind of maintain the baseline and really enhance the services that was being provided. So our consultation process remained the same for physician staff. Our order entry process remained exactly the same for clinical pharmacists. They used a different PN order entry system, but other than that, that was really the only change. And then turnaround time expectations were the same. Order cutoff expectations were still the same. So that interdisciplinary collaboration was really key for some operational efficiencies. And then real quick, because I realize that I get long-winded and talk too much, but we're going to quickly go through some real-world outcomes that we were able to see on our insourcing journey. So we'll start with cost savings. That's always the big driver for a lot of projects like this. After all, the saying goes, no money, no mission. So the original savings projections were intentionally pretty conservative. We didn't want to overpromise and underdeliver. So we based it off of some conservative assumptions, and we were really able to outperform those, which was great. From a real cost perspective, we were able to realize savings of roughly 50 to 60% per bag on standard formulations. And then 30 to 40% per bag on custom formulations. So we track that annually every single year. For 2024, our total annualized savings was just over $1 million based off of our, volumes and the bags that we did. And that value level has been pretty consistent since we started insourcing. Additional benefits you have to touch on is better quality control. So we have greater transparency and accountability for the quality of the compounding operations. Before, we could certainly, reach out to the third party who we were using to compound these bags and request any kind of information be sent over. But you had to submit that request. You had to wait for them to gather the information. You were always kind of asking in the back of your head, was this scrubbed in any kind of way? So the additional transparency around the documentation and then the additional assurances that we've been able to gain with our in-house environmental monitoring team have been huge when it goes towards quality control and confidence in that quality. And then frontline staff satisfaction, obviously very important, but we saw, huge improvements in communication. We've highlighted a lot of those already. Flexibility and accommodating order changes. So if a campus gets a late order, if a order gets discontinued, if a lab comes back and something needs to be changed, we can be pretty flexible in accommodating those, whereas before it would certainly amount to a wasted bag. We also have full control of our operations during disaster situations. So here in Florida, it feels like we go through a hurricane at least once a year. That hasn't happened this year, so knock on wood, we've dodged it for this year, but it's not uncommon for us to need to make a pretty rapid plan around how we're going to service the facilities in the event of a disaster, and I think we have a pretty good process outlined for that. And then lastly, we're able to make some impactful changes to the process relatively quickly. So if a frontline staff member identifies a template that should be tweaked, or, a warning level or limit that they think could be optimized, we have a great process to solicit that kind of feedback, have it reviewed, and then implement that pretty quickly. For balance and full transparency, I feel like it's important to talk about challenges as well. And so, IT issues, I won't pretend like it was super smooth. We have had our fair share of IT issues. Since we're an off-site location, sometimes it's hard for us to get support. We've had internet service or network outages. While the compounders are very reliable, there's been unintentional damage that happens to those, or times when it's malfunctioned, although rare. So definitely things that you have to overcome. You want some experts on your staff who are able to triage those issues. Additionally, with the PN order entry system, because the application was seen by our internal IT department as a departmental application and not a more global clinical application, the team here at the CFP facility ended up kind of being application administrators for that product. So we were adding new users. We had to add new workstations whenever stuff like that came up. And so that was a really heavy lift early in the process. Now that we've tweaked that, the way that looks a little bit, it's much more streamlined now, and we're just adding new users when they come up. So definitely easier, but was a hurdle at the beginning. And then in managing the operations, obviously you have to make sure that you have a great staff who has the right background knowledge and specialized training for this kind of work. We sometimes have challenges managing labor demands. So trying to sync to fluctuating ordering volumes, not knowing today if it's going to be much less or much more than the day before, can be tricky. Being the PN police can be not so fun. So while I mentioned that being able to make those exceptions for folks is definitely a benefit, also having to enforce order cutoff times sometimes is, doesn't really win you any popularity contest. And then lastly, we as we switch gears from kind of being in an implementation phase to being in more of an optimization phase, we have been really encouraging the use of standard bags where it is clinically appropriate, working with our clinical leadership teams to push that message. And that is not always super well received, but we have made some ground on that as well. And so wrapping us up here in conclusion, I hope that was helpful for you all. I hope that I was able to provide enough evidence and convey that standardizing clinical processes really does help drive evidence-based practice and supports better patient outcomes. Optimizing centralized sterile compounding operations definitely leads to better workflow efficiency and patient safety. And then while there certainly are challenges that we shouldn't overlook, insourcing PN compounding can result in significant cost savings. It can provide enhanced quality assurance and increase frontline staff satisfaction and engagement. And with that, I will flip over to my reference slide. And that concludes the content that I have prepared for you all today. But with a quick time check, it does look like we should be able to take a few questions if there are any. So Melissa, I'll turn it back over to you.
Thank you, Abby. Thank you so much for that great presentation. As a reminder, be sure to enter any questions you may have from the webinar in the Q&A box. But before we get to questions, I want to draw your attention to, let me take control, to this screen. We have a QR code that will lead you to a short survey. Please share your feedback, as we're always looking to make these medical education webinars better, and we're really interested in potential future topics that you would like to see. Abby, we did get a few questions. I am going to, I don't know if you can see the Q&A box on your own screen.
Let's see.
Yes, I'll let you look through these and see which ones. There is one about beyond use dating. How do you determine beyond use dating of your batch standardized bags and the ingredient stock solutions? Have you done stability studies for extending beyond use dating?
We have not done stability studies for extending BUDs for our PN products. So whenever it is something that we're familiar with, whenever we first made our plans, we did a lot of stability studies on those 19 strategic products that we thought we were going to be providing for the company. And so we have a great relationship with a lab that's able to do that work. We haven't done it on our PN specific supplies just yet. We follow USP recommendations, and so many of those stock and pooled solutions are just made for the day. They can't be kept, but we were able to find some literature, both just published literature as well as in some of the package inserts for some of the specific indices that we use around stability of those products. So because the standards don't have a ton of additives in them, everything in there is pretty stable, and so we are able to get 10 days refrigerated on those. And because they're big, we really don't want to batch compound much more than that. We really don't have the refrigerator space to store much more than that. So what we do right now is working, and so we haven't pursued that, but it's definitely been something that I've thought about in the past.
Very good, thank you. Another question, our hospital pharmacy AHS proposed using a premixed product containing electrolytes, and then for patients who have different electrolyte needs, using a non-electrolyte containing premixed product and doing all electrolytes outside of the bag. Are there practice guidelines around this or other places that you know of that do this? And currently they add electrolytes to the premixed product, but claim that that is too error prone. So I don't know if you have any experience and can speak to that.
I don't have a lot of experience with this. I don't believe, don't quote me, but I don't believe that there are practice guidelines that specifically address that question. I think it's a great question. We've thought about that, especially as we've developed our standard formulation. So, again, purely from a cost perspective, is it more advantageous to include your FOSH replacement in a bag versus, compounding that FOSH replacement outside of the bag? And I think a lot of it is probably institution specific. So I would say if your specific health system has a hard time with technician turnover, if you're having a hard time staffing your clean room, then put that work on your centralized team, put those electrolytes that that you're confident that need to be replaced in the bag. Otherwise, it's a little bit of a balancing act if you try to optimize it too much, especially if you're trying to do it based on price. If you say, oh, potassium will replace inside of the bag, but phos we're going to take outside of it. So it probably didn't sound like it. We try not to micromanage that part of the patient care piece of it all so much. I don't have a super good solution or answer to that. It's kind of just filling it out case by case. We don't have a hard rule that, this must be done outside of the bag for those specific electrolytes, or this must be done included in the bag.
Very good, thank you. Another question that we got, have you had discussions regarding discontinuing the term TPN and switching to central PN or peripheral PN?
Yes. And so if I accidentally said TPN, know that it's just antiquated and I didn't mean to say that. Melissa and I actually had a quick chat about the difference between TPN and PN and how TPN is kind of phasing out. So yeah, we have standardized, we've tried to standardize our language to follow PN, as total parenteral nutrition might be a little bit misleading.
Very good, very good. And then there's some two questions just about your additives, maybe just curious about your practice at Advent Health. About using potassium phosphate for your pediatric and neonatal PNs due to the aluminum contamination. And then also just a question about adding chromium, but not additives like insulin.
Yeah, so for the for the pediatric PN formulations, we do allow a few additional additives for that specific reason. We went through and did a review of all the NDCs that were on the market that looked specifically at the ones that are our preferred products and really try to dial into that aluminum toxicity. So yeah, it's definitely something that we keep in mind, especially for those tiny, very concentrated bags for our teeny tiny patients. When it comes to chromium, but not other additives like insulin, insulin was an easy one to take out of the bag. We had instances, and I think it's relatively common, commonly cited, where you put insulin in a TPN bag, a patient goes hypoglycemic, they need the rest of that nutrition, but they don't need the rest of the insulin that's in the bag. So kind of as a mechanism to make sure that patients are able to get their as close as they can to their full nutritional requirements, we have taken that insulin component outside of the bag. Chromium, not a super commonly used additive for especially our adult patients. We see it more in our pediatric population. Partly centralizing that inventory. Chromium's not especially cheap. So we're able to centralize that inventory at one location, included in the bag, and then not have our 9 separate campuses have 9 separate inventories of that medication.
Very good. And one final question, we just have like 2 minutes left. You mentioned that all your sites are within 30 miles of each other. Is there a distance limit by law or practice that you are limited to be able to distribute PN from a centralized location? I have been told there may be interstate.
So in the state of Florida, there is not. In the state of Florida, we are able to distribute to our own use facilities through what's called, it's a class 3 institutional permit. So as long as it is an Advent Health facility anywhere within the state of Florida, we are able to distribute product. So no issues with that here, thankfully. That 30-mile radius is really key. I know a lot of folks who are opening centralized services centers, and they're servicing people in multiple states. And so I can't imagine that. In Florida, a lot of our healthcare is pretty concentrated, and that's certainly the case in the Central Florida division here. We've got a ton of sites right here kind of on top of each other.
Very good. Very good. Well, thank you, Abby, for taking those questions. And as a reminder, a recording for this webinar will be posted to our medical education website. If you're not familiar with the site, you can scan the QR code, and I will also put the link in the chat so that everyone has access. If you want to scan the QR code, you're more than welcome to do that as well. We want to thank you so much for attending today, and thank you to Abby for a great presentation. We look forward to seeing you at our next webinar. Have a great day.
Thank you all.